in this talk, I'm going to discuss a little bit the current and potential role of imaging for COVID-19 disease management, mostly targets from what we know today from detection up to what we can foresee related to characterization of the entire patient trajectory, so from the diagnosis phase up to actually follow-up. So as an introduction, so just a recap, a little bit what it is known today from the SARS-CoV-2 virus and how it engages cells. Just a brief review on the investigation therapeuticals on that are ongoing, together with status of vaccine development and what can be foreseen at this moment in time. And then a cornerstone of management of this disease, that is through the molecular PCR diagnostic, and how from the interplay with this PCR diagnostic imaging, namely CT, come to a specific role. So at that time, then I will focus a little bit on the clinical presentations, the most frequent of COVID-19, but there's also atypical, and what are today still challenged, how to use CT, namely, and in this arena. And so I will discuss a little better as well about some controversies around CTs, how there's difference between different countries, and what are the current thoughts of international societies, namely RSNA and the Flash Society. So this new virus that we have, that the world is facing today, so it's a virus that is structurally very related and close to the original SARS that started in 2003. In total, we have now, so there are typically 6 different species of coronavirus known in humans. We have one species that is divided into 2 strains, and in total we have 7. Of these 4, these are typically common for the mild symptoms from common cold, and the 3 ones which are more severe, so the original SARS, the Middle East Respiratory Syndrome that appeared later, 7 years ago roughly, and then the current virus that we have, SARS-CoV-2. So the typical interesting on this virus, so it's that similar to SARS, is that there is a key through the what's called spike S protein. You see it here in yellow, where it will engage cells, especially the ones in lung. So the ACE2 is where this spike protein will bind in the lung, and up to facilitation, then there's a normal virus cycle with replication and with ACE2 downregulation. At that moment in time, so as part of this cascade, so we have a local that then can become a systemic infection that can be potentiated by the cytokine storm. We have then all the series of effects from the lung injury per se, but as well effects on myocardial and as well the increase of vascular permeability, which makes this disease complicated to manage in some patients. So the therapeutical approaches, they are different axes. So the most successful so far that got recently the emergency approval in the US and also generalized use in the European Union. So remdesivir, it's been basically an IV drug and basically limited to patients which are in more hospitalized because of the way they deliver. Chloroquine has been received, and the family has received significant interest. However, I think the World Health Organization has temporarily suspended its use because of some adverse events through this drug. Still with IL-6, so there's been some use, namely as inhibitors to control the cytokine storm. And I think that in China, namely Actemra, has been deployed. So today the world doesn't have that much options in the plate, and I think that we'll have to see still significant improvements over the next years on this area. But again, like HIV, it also started with limit of success, and then the world has achieved a great capacity to manage HIV. So I think remdesivir will be a good starting point here. So vaccine development, I will not spend too much time. So we all know multiple vaccines being developed so far. The normal paradigm of vaccine development takes a significant number of years. Today, we're trying to accelerate this timeline. What it happens is that manufacturers will need to invest in capacity to deploy these vaccines, even without knowing that they will be successful. And we are seeing several efforts from pharma on building large-scale manufacturing as a bet. We know that from the typical timelines, the best that we can get most likely to be something at the end of this year, and very limited supply. So most likely we are talking at least a year ahead of us, in case one of these vaccines gets efficacy and safety, good performance. A central part, and also because this somewhat then is binds to how CT is used. So the COVID-19 testing, its diagnosis basically on PCR. As we know, many places there's limited capacity at this moment. We have seen increase by manufacturers to try to get, namely, point of care testing with fast 5 minutes. It's still ramping up capacity. So many places in Europe, it's not possible to test all the cases that are suspected, and testing might be just limited to patients which are already in a state that they need to be admitted into the hospital or being evaluated at hospital. In parallel with the testing, so there is also being wrapped up tests for antibodies to understand how the development at the population level of immunity for this disease happens, so that there's a better grip how to manage the different waves that we might see in the future. So the COVID-19 symptoms timelines, there is typically a window of about 6 days before the initial symptoms. So that will be cough and sore throat mostly. Then fever usually will present. And between the 6 days between the onset of illness and hospitalization is an area where therapeutics, if successful, could make the best outcome. So far, like I said, so remdesivir is basically for patients which are already hospitalized. So the disease per se shares the phenotype that's very close to SARS and the Middle East Respiratory Syndrome as well with the flu influenza, so the H5 and H7. It's very difficult to manage clinically on a specific subset of patients. There is limited role for bacterial superinfection, but cytokine storm plays a very significant role in this disease. Trying to manage this has been shown with SARS already challenging. So besides the viral pneumonia per se, the role, comorbidities, namely cardiovascular, play a significant challenge in how to manage these patients. So typically, real-time PCR will be done between first consultation up to hospitalization, depending on which stage. And then there will be, at the end, that the patient is discharged, for example, for the patients that will be admitted hospitalization. We have seen CT that traditionally is something more delegated to the actual patients who is hospitalized to be brought up to the initial diagnosis phase. And I'm going to describe historically how this has happened. And we are also then, of course, for patients that are hospitalized within treatment, but as well for follow-up. So because several of the sequelae may require additional CT. Some countries in Europe are now doing recalling patients after 3 months after they are discharged. So in terms of software applications, so because of between diagnostics, treatment, and follow-up, we see basically 3 classes of what we anticipate how medical imaging software tools will assist management of this disease. So the first one is basically as part of a computer-aided detection, and here software. So this software is basically targeted to automatic detection, quantification of pneumonia infiltration, and labeling, so TGOs, ready paving, for example. Typically, because there might be important comorbidities at play, usually those should be also be detected at baseline, for example, that might not be known for the patient, namely heart. And we are seeing, typically, at least in the Netherlands, so a significant number of patients on ICUs have some level of pulmonary embolism. So this is a part as well, as part of management that needs to be addressed. Again, it might be that software tools go mostly in pneumonia infiltration quantification, but we are seeing as well the opposite, that is to try to quantify how much is the lung parenchymal still there. So this is mostly as part of diagnosis phase. And then we see that they'll be needed to compare multiple time points. So after there's the baseline and there's an infiltration, we need to quantify these a function of time. And this might be either between patients which are high risk and they might need to be hospitalized, so in case to detect this progression, but as well follow-up after 3 months. A third class of software that is related to computer-aided detection is the computer-aided diagnosis. So here is mostly, there are 2 classes. One class is typically to differentiate between COVID-19 and other forms of viral pneumonia or bacterial. So there's some cases in China where this has been attempted or proposed, let's put it like that. And the highest interest will be to identify which patients at baseline combining with the other symptoms might be a risk, for example, of being admitted to an ICU, or if there's any chance of predict what will be the progression. Here, of course, it's not only progression, this will depend on which type of medicines then are approved for treatment. So the emergence of CT in screening has mostly, as you all know, been introduced in China. And it started because historically the number at one point, I think 3 or 4 February, the number of daily cases went down, and it was clear that this was not because there was less cases, but actually because there was exhausted bandwidth to do testing. So at around 12 February, there's a large spike. So when a significant number of patients were then reassessed based on CT. So 97% of cases with a PCR positive also have CT findings compatible with pneumonia. This was a large study with around 1,000 patients. The approach was later used as well in France, if there is a CT capacity available. So it has been France and Italy, they have used it. Germany, the Netherlands, there's also being used in that approach. Although, as I'm going to see, its use for screening is not consensual. This is an interesting in Italy. So typically at the start of the crisis in COVID-19, still a significant number of cases were negative or indeterminate, and as the prevalence of COVID-19 appeared, a significant number of it was very clear that a significant number of cases would be positive for COVID-19. So a PCR test at the time takes between 10 to 15 hours, and these patients will then receive will be scanned so that they can be a triage and they can be separated in the correct terms, so that they don't need to wait 15 hours until the decision is made. So that is somewhat the rationale why CT has been used in this setting. So the most number of cases of initially, let's put it like that. So the early manifestation of COVID-19 mostly at large majority of the case, so between over 15% will be ground glass opacities. At the disease progression, that usually will start between 1 to 2 weeks, there will be consolidation appearing, so as well as in a significant number of patients. And then there are 2 patterns usually that includes, namely with infiltration of lymphocytes, that is the crazy paving, which is not, which is typically a sign of, again, progressive disease, as well with reticular pattern. So these are 2 hallmarks typically considered of progression. So some from RSNA, some typical CT presentations. So So at the start, so bilateral multifocal rounded GGOs that appear, so in a 52-year-old man and a 29-year-old man, this already starting with consolidations, with surrounding GGOs. The COVID-19, however, is not, there are atypical presentations which may overlap organizing pneumonia and as well H1N1, most common influenza. These are typical examples where they might be a significant unclear of what it is. So that's why one of the reasons that CT alone might be considered not be enough in order to differentiate between different forms of pneumonia. And that is one of the things that the societies have tried to evaluate. Of course, that if you are in a time of the year where influenza, for example, is not likely, that's one thing. But if you think that COVID-19 might overlap with influenza activity, like in the Northern Hemisphere is expected for next October, this is something to consider at the time doing analysis. So here we are mostly looking at typically 2Ds, so axial interpretation. There's also been attempts to use, for example, 3D imaging to depict, so renderizations to depict how does this, how is the initial infiltrate distributed, and as well to understand what all marks of progression. So as of today, so in the US, so a little bit now time to review this. So the CDC and the ACR recommendations is that CT is not currently recommended, nor chest X-ray for screening or diagnosis. Although there are experts which disagree, because this depends a lot on the PCR. And if PCR is available, so this is considered to be the only specific method of diagnosis, even if the chest X-ray or CT findings are suggested. And again, and this is because it's considered that its findings are not specific, so because they might overlap with influenza H1N1 and with with adenovirus. So SARS is not in circulation today. And because in a lot of countries, we know that PCR testing capacity might be overrun. Because you might have much more patients that PCR capacity in time. So in that case, CT can be considered, and then two things might happen. So CT can be considered only in symptomatic patients after the triage of clinical findings and the patient story is consistent. So that is one of the options for CT. The other is if the researchers in the hospital make it that CT capacity is enough, and so usually CTs might need to be sterilized after there is downtime because of this process between different patients. So, but if the capacity is also enough, so that one CT, for example, are reserved for this type of patients, then the indications might be broadened. Otherwise, usually this will be limited to critical or high risk. We have seen, at least in Europe, that there is a significant, the flow charts of diagnostic depends a lot, and the interplay with CT, how CT is depends a lot on this hospital preparedness and how much CT capacity is free to dedicate it for COVID-19. Therefore, we are seeing is that the standard flow charts or guidelines are still not much well established. But we suspect over the next months these might have a change. So as part of our SNA, so our SNA basically defines a language of 5 types of reporting. So and typically they split between appearance, which typically are compatible with COVID-19. So they mark it as COVID-19 typical. Then there is things which might be intermediate, so that's not completely clear. COVID-19, so there will be other options. So this will be COVID-19 indeterminate, and then there's additional tag that is the two ones. One that is clearly CT findings are not compatible with pneumonia, and the one which will be appearance. That will be atypical, so that might be overlap with significance, or they are not at all typical reported for COVID-19. So usually, so RSNA provide a specific reporting language, so to include these different schemes. And one of the objectives of also this keyword is that in the future to allow this reporting to be used for data mining, namely for development of additional software. So with the Fleischner criteria, so that's also more recent. So the Fleischner criteria, so it's a multinational consensus statement. What it was indicates that imaging not indicating patients with suspected and that have mild clinical features, unless they are at risk for disease progression. They indicate with patients which already are diagnosed with COVID-19 and that have a worsening respiratory status. And again, so if there is in places where PCR might not be enough, so imaging CT, namely, is indicated for triage. In parallel with this, so the Dutch Radiological Society then have decided what is now called CORAT classification. So they basically provide a 5-point scale of suspicious between 1 and 5, for that will give some way, how likely it will be that is a COVID-19. So 0, it's a complete, you cannot, it's a scan which is not interpretable. 6 is one that is proven by PCR, and then 1 to 5 is between very low and very high of a pulmonary infiltrate by COVID-19. And so the initial the experience with this was not bad at all. So and therefore this has been proposed. So the area under the curve is about 0.91. So it is something that has been proposed. We need to see how worldwide this classification scheme will be used. Again, so what I've discussed briefly was CT in the role of screening and initial screening and initial diagnosis and associated reporting. We see as well multiple uses of namely software to do automatic detection of the infiltrate and try to compare how does the volume change as a function of therapy or just supportive care. It is the fact that therapy is not established yet, so the patterns of response might not be completely clear. It means that namely using artificial intelligence options to try to predict patient prognosis might not be still completely clear. So we mostly, in terms of treatment response, the typical endpoints which might be surrogates of clinical outcome will be the combination of the velocimetry of the lesions and the classification of GGOs, predicting or infiltration. Okay, so that's just an example. So here in a patient with cytokine store, so it is a patient that typically at one moment needs to start receiving oxygen, and typically at that moment they started with an anti-IL-6, so to control the cytokine, and plus an HIV retroviral, so off-label use, and still overlapping with antibiotics for secondary bacterial pneumonia. And so as you can see, the partial resolution on day 6 after the patient starts with the duration. So in this particular case, you could imagine that this type of software might be used to do an automatic comparison with the baseline, and then based on other parameters try to anticipate how recovery will happen. I think this is my final slide. So we are seeing, or at least in North Hemisphere, so fall winter, there's one reason of concern is that it will overlap with influenza and with normal human HCOV and alpha-CoV activity. These will make differentiation at the start more complicated. So one thing that will help is that the PCR availability will be expanded over the next 6 months, which definitely will help. And this is important because if we don't have, in the absence of an effective vaccine that provides long-lasting immunity, this virus might gain seasonality during 2021 and might become endemic so that it gets established into the human population. So it will be something that it will not go away. In this setting, so with PCR increasing, the typical places where we expect CT still to be used is basically complementing PCR in patients, high risk, patients at risk, and addressing as well cases where PCR might be exhausted capacity, or there is suspicion of false negatives. So we know that depending on how the sample for the PCR test is done, there might be still false negatives. And again, so follow-up patients will be required. We are seeing namely fibrosis happening at a much shorter time scale. So things after 1 month, it's already a significant. Some patients might have significant fibrosis that you will not see in traditional. So in that way, we are still seeing how this disease will evolve. I think there's still a lot of things to learn, and the key message is that imaging will need to adapt to requirements as soon as additional evidence is known from the field. And yeah, and I think that is my last slide. Yes, thank you.
Hello, Pedro, and
yeah.
Thank you for the class. So let's switch now for Portuguese, ok? O Pedro é português, então a gente pode agora bater um papo um pouco mais em português para a sessão de perguntas e respostas. Então fica à vontade para postar suas perguntas ou no chat ou na sessão Q&A. Uma primeira pergunta que eu tenho aqui, Pedro, pensando, né, até pela dificuldade, pelo que entendi, né, a tomografia ainda é um método recomendado, né, para screening e diagnósticos, em alguns casos mais específicos. Ainda tem várias discussões na sociedade sobre isso, né. A minha pergunta é referente, né, eu sei que você representa o time de pós-processamento avançado das soluções de software da Philips. O que a Philips está fazendo em temas de desenvolvimento de software, né, usando inteligência artificial, para ter alguma solução específica para isso, para esse ano, próximo ano? Como que a gente, como empresa, conseguimos ajudar a sociedade e os médicos também?
Sim. Pronto, nessa área, aquilo que nós temos feito, está em curso, portanto, é uma atividade de desenvolvimento. Portanto, nós vemos a inteligência artificial como podendo auxiliar a parte de detecção, mas também auxiliar a parte de quantificação. Portanto, anotar destes casos para ter uma ideia dos volumes. Se não for usada uma técnica simplesmente de thresholding, são técnicas que demoram uma delineação das soluções que podem demorar imenso tempo. E, portanto, o que nós estamos a ver é técnicas de inteligência artificial para fazerem automatização, de alguma forma, a partir do momento em que o doente está na CT e há o protocolo, e é feito um protocolo para despiste do Covid-19, que automaticamente, após essas imagens estarem feitas, que haja um software que faça a análise da imagem e coloque no PAX a primeira estimativa para o radiologista ver, interpretar e auxiliar este processo. Claro que se tivermos isso muito bem no primeiro diagnóstico, para aqueles doentes que vão ter de ser admitidos, fica uma baseline, fica muito bem definido e a seguir auxilia todo o processo, digamos, no caso do doente ter uma pioria de sintomas e, portanto, tenha de voltar a ser feito, tenha de voltar a fazer feito um novo scan. Portanto, se é uma área que a Philips está envolvida, temos ligações, ainda temos interesse em colaborar com hospitais que queiram, nomeadamente, participar neste desenvolvimento e que tenham interesse em fazer um co-desenvolvimento conosco e também aprendermos das experiências, porque nós vemos que existem experiências muito variadas de acordo com o país e porque no cenário em que há imensa pressão nos sistemas de saúde, há variações entre países. O que é bom para um pode não ser necessariamente o adequado para outros. E, portanto, isso é uma área que na Philips nós temos em desenvolvimento. É algo que nós não temos soluções num ponto de vista de imagem, de suporte para tórax. nada destas soluções foram desenvolvidas especificamente para a Covid-19, porque não existia, e como utilizar estas aplicações para a Covid-19 é uma área que também estamos em comunicação constante, em tentar perceber como é que o software pode vir a ser utilizado, quais são as alterações que podem ter de vir a ser necessárias, e algo que é importante perceber é que um software pode ter sido licenciado pelas autoridades de saúde dos vários países numa determinada população, e isso não quer dizer necessariamente que nós possamos utilizar para doentes de Covid, e isso implica do ponto de vista da Fields que nós temos também de estar em contacto com as agências reguladoras para perceber, um bom exemplo foi a cláusula de emergência que a FDA nos Estados Unidos permitiu, que faz com que o processo de implementar software específico seja acelerado, pelo menos enquanto a situação de emergência estiver em curso. Portanto, isto é só passar a mensagem para a área que estamos a olhar ativamente.
Legal, obrigado, Pedro. Uma outra pergunta aqui, né, da Karina, como eu faço para fazer parte da equipe de desenvolvimento de software e qual que é a formação necessária, tá? Essa é a primeira pergunta. E uma segunda pergunta do meu lado, né, bom, se tem algum hospital, uma instituição de saúde que queira ter uma parceria com a Philips para desenvolver algo ou trabalhar em conjunto, se existe algum processo, né, como essas empresas, até hospitais ou startups, conseguem entrar em contato conosco e começar um diálogo, caso a Philips aceita alguma abordagem nesse sentido.
Nós geralmente, até devido em condições normais, nós estaríamos ativamente a visitar os vários hospitais que estivessem interessados, devido às atuais circunstâncias, com as imensas restrições de viagem e os primeiros contactos geralmente que nós fazemos é que dependemos dos mercados locais. Portanto, se os mercados locais se encontrarem da comunicação com os clientes, houver uma identificação de sites que estejam interessados em fazer esse desenvolvimento em conjunto e, claro, e que depois possam fazer uma primeira identificação e que depois possam discutir com as pessoas, com as várias unidades de investigação dentro da Philips, para a qual depois possa haver um contacto posterior para identificar o que é que poderemos fazer em conjunto. Portanto, isto é tipicamente como é que nós estamos a operar na Europa. Ou seja, os mercados locais são a principal porta pelo qual nós estabelecemos contacto e que nos trazem essas possibilidades de colaboração.
Legal. E voltando aqui na pergunta da Karina, Pedro, quando a gente desenvolve um software, né, como que a gente trabalha, né? Então tem uma opinião clínica, um médico, né, um hospital. Eu acho que tem os cientistas de dados, né? Como que é composto o time para desenvolver algum software médico, né? Só assim, em linhas gerais, educativa, né? Como que é feito?
Gerais. Ok, linhas gerais. Portanto, nós tipicamente temos uma equipa de desenvolvimento. A equipa de desenvolvimento discute com os hospitais e também com base em publicações médicas, identifica uma determinada área na qual podemos produzir um determinado software. Depois existe uma fase no qual fazemos uma parceria com determinados hospitais, de maneira a que termos dados de doentes para testar um determinado algoritmo, e isso é chamada parte de desenvolvimento, e depois há uma parte de avaliação e de validação clínica. Isto também é feito com outros hospitais, podem ser os mesmos ou outros que estejam simplesmente envolvidos na parte de validação clínica, no qual o software em protótipo é avaliado para saber se é seguro, se tem eficiência clínica, o que permita mais tarde permitir a autorização para entrar no mercado. Portanto, em linhas muito gerais.
Legal, obrigado, Pedro. Bom, está bem claro. Obrigado novamente pela sessão. Não temos mais nenhuma pergunta no chat ou no Q&A, então se alguém tiver mais uma pergunta, fica à vontade. Estamos bem no tempo. Eu acho que dessa vez a gente vai terminar um pouquinho mais cedo. Surgiu uma pergunta agora, uma última pergunta do Tiago. Uma pergunta, acho que seria os Estados Unidos, o USS tem aplicação no diagnóstico do COVID? Ultrassom, desculpa. Ultrassom tem alguma aplicação no diagnóstico do COVID?
Sim, foi usado, sabemos que foi usado em vários sítios com algum sucesso. De Espanha houve uma utilização bastante, houve uma utilização, houve recentemente alguns papers que demonstram que pode ser usado e desse ponto de vista tem algumas vantagens para um primeiro assessment. Claro que pode haver claro que a baseline para ser estabelecida deveria ser CT, mas em casos no qual um CT não existe ou não haja capacidade instalada, o ultrassom, nós sabemos que existem e começaram a haver imensas publicações ao nível da utilidade do ultrassom também para diagnóstico de Covid.